His respiratory trial, it's even harder to get people to do exercises and to track that over time. So the research is very limited, and the trials generally are within 4 to 6 kids, maybe 12 kids at the max, and all the results come to a conclusion that there's insufficient evidence to show that it's helped or not. But basically, so I don't want us to say not to do any exercise. There we go. But I think it's still important to incorporate exercise as part of your lifestyle, whether it be something simple as stretching or aerobics, and we'll kind of go through some of that. Oops, let me take it to, okay. So I'm not going to go through the contracture management because I'm hopefully, Dr. Roye or Dr. Spiegel will talk about it. So basically, I wanted to talk, exercise should be of 3 components. One is stretching, strengthening, and aerobics. So stretching, because you want to make sure that you are maintaining proper range of motion in hopes to avoid a contracture. And as many know, contracture management is one of the most difficult challenges that you have with collagen 6 disorders. The use of stretching equipment through standing frames, splints, bracing. I'm not going to go into very much detail about that because that is all specific to everybody, child specific, but these are the things that you would want to use in conjunction with everything else. So again, this is a 3-pronged approach for managing physical activity in children. The next one has to do with strengthening. It could be isometric, active, and then strengthening. So strengthening could be using something as simple as bands, could be used water, and I'll go through some equipment in terms of water-based therapies. And then last but not least is aerobics. So not only do we want to do exercise for strengthening and stretching, but also for heart health. We're also having to live with longer, and you need to be able to make sure that you have fitness levels, improved fitness levels. So that's why I encourage everybody to be involved in some type of aerobic activity, and we'll talk about some of that later on. So how many, so my student helped me make these slides. So how many Robins have partnered with Batman? I did not know this answer. So he tells me 5, so, but then I asked him, how many Batmans have there been? So I don't know about that. So anyway, so I'm going to go through these really quickly, but basically just to give you an idea of how many articles there are. This is a systematic review of standing frame exercise, standing frame recommendations for children with cerebral palsy. So these researchers, they scoured the literature, they went through 7 databases, they found over 600 articles, and only 300 articles actually met their criteria for inclusion. And basically, what they said, even after reviewing the articles, there was insufficient evidence to show that these things work. But having read all these articles, they said that we still recommend 60 minutes a day to decrease hamstring tightness of a standing frame, 60 to 90 minutes a day to improve bone density, and then 60 minutes a day to improve hip biomechanics. That's a lot of time. So even if you did 90 minutes a day, that's 90 minutes out of your day daily for the bone density. So I don't know if very many families doing that. And again, to try to get that into a research study, to be able to follow it over time, it will be very, very difficult to have someone to follow through. So then this is another study with specifically with boys with Duchenne. And they only had 4 boys in this study, so that was difficult. And then they just took a weekly stand time. The weekly stand time ranged from 1.3 hours to 3.3 hours. So if you take stand of 1.3 hours over 7 days a week, that's barely 20 minutes a day, maybe even. So again, they showed that there was insufficient evidence to show that it helped with bone density. So I'm going to just kind of quick through all these. This is using upper extremity for strengthening for boys. Again, they had 30 boys, a 24-week intervention. They used assisted bicycle training for arms and legs. And they found that it was feasible and safe, and it helped to slow down the decline of the boys' upper extremity function. So this is something that I'm actually looking at more and more in terms of upper extremity movement and monitoring upper extremity activity, and then I'm going to talk about that a little bit later. So making you wait for all this. That's the teaser. This was a new study that I saw just recently. It's a 2017, and it looked kind of interesting. So they were using a home-based exercise program, so like a Fitbit, or not a Fitbit, I'm sorry, a Wii Fit or a Kinect system to do some exercise training in children. And they used a polar monitor, which is a commercially available monitor that runners use to check their heart rate. And what they found was that it was actually, it was safe to use, and it was cost effective is what they were trying to say. They, to compare it using the polar monitor, which is polar heart rate monitor, which you can get from Sports Authority, actually not Sports Authority because they're bankrupt, but Dick's Sporting Goods. You can get it for about $150 versus a Halter monitor, which is very expensive. So what they were trying to show that it is feasible to use at home. So I think what they're trying to encourage is for a therapist or clinicians to start incorporating this as part of an exercise program for the home-based exercise program. So gaming is a big thing now, using Kinect and the Wii. I like the Kinect better because you don't have to have a controller. It's the kid that's controlling, and so that's something that I have to ask the parents on the side, is it okay to do a gaming system? And then we talk about Kinect. This was a study that was attempted in the UK, and it was to look at water-based therapy, and they I think they tried to, I think it was over 346 boys in the UK, and only 12 boys consented to participate in this study. And then overall, they had 12 kids that, 8 kids that did the aquatic base and 4 kids that did the land-based therapy. And again, it concluded that they didn't have enough evidence to show that the water-based therapy was helpful, but it is something that I recommend a lot for the children as water-based exercise because it's safe, it's helpful in terms of strengthening, and kids like it. So that's another. It is a challenge to get the kids to the pool, so that's something that we have to be mindful of. And then this was another one looking at upper extremity strengthening. This is using another device called a MotoMed. It's an upper extremity ergometer or a lower extremity ergometer. And if the child is weak, then it will take over, the device will take over and pedal for the child. And then when you have a little bit of strength, the child can pedal the bicycle, the upper extremity or lower extremity. So this study showed, this was also recent, it showed that ergometer training did improve endurance and ADL performance. It didn't have any change in strength, but it was only an 8-week study, so that's not a long enough time to make sure that you have changes in strength. Okay. So again, I'm going to just go through all this because this is basically, that shows you how few studies there are. The fact that I can put them all in one slideshow, but a lot of these are insufficient evidence. So let me just go through all this. And the last one, I think this one. Okay, so back to this one. Again, so I don't have much evidence to show you that exercise is helpful, but we know it's helpful. And it's good for psychologically also for the kids because this is the one part of their life that they have control over for adults or children. I don't have control over in terms of what's going on with the disease process. I'm developing contractures, but I know that I can change my strength by doing it. So this is the one thing I spend a lot of time spending with the kids to let them know that having mom and dad do the range of motion is only making mom and dad stronger. It's not making you stronger, but you have control over your strength. So it's very important for you to be able to do this. So I have to make sure that I get the buy-in from the child to participate in an exercise. Okay. So I'm going to talk a little bit more about this, but exercise appears to be safe. We spent a lot of time talking about inspiratory muscle training, so I'm not going to talk about that. The one thing that we talk about is the eccentric muscle contraction, and this is what we have learned from the Duchenne literature. There's nothing in the CMD literature about eccentric muscle contraction, so all of our exercise recommendations are based on what we've seen in the Duchenne population. So eccentric muscle contraction is, if I take a weight and I lift a weight, that's concentric, but then if I lower that weight, that lowering that weight is eccentric muscle contraction, which is unsafe in kids. So, kids with Duchenne. So we are using that as a global, like for all kids, so we are not going to recommend that. So it's very important to make sure you do that. And then we talk about high resistance training, just small weights, light weights, high repetitions is what we would recommend for them. And then avoiding exhaustive maximal exercise, and then lastly, more research is needing, but I'm not going to talk about that a lot. Okay. So stretching, I'm going to just go through a bunch of little, so these are all exercises that I'm sure you've seen in the past. Everybody's given you, you've gotten them over and over again from your physical therapist, and your kids hate to do them, you hate to do them, you hate making them do it. So, but my feeling is that if you can find one or two exercises, and if your therapist is cognizant, I think it's important for them to incorporate in your daily life. This is really important. If I try to recommend them to do 30 minutes of stretching every day, it's never going to happen. I have a rule of 3, and I stick to that rule of 3 no matter what happens. I only give 3 exercises, and if they can go, so it's my job to figure out what is the most important, and I try to make sure that the kids are able to do it by themselves. If not by themselves, then when they're doing something else. If they have to do some heel cord stretches, do it while you're brushing your teeth. Most kids hate to brush their teeth anyway, so do that with it. Or hamstring stretches while watching TV. There's a way to do a long sit stretch while you're watching TV or playing your game or something like that. But there's a way to incorporate in your day-to-day activity, which is the most important. I feel that that's what's going to keep the compliance in terms of doing stretching exercises, which everybody hates. And the other thing that one of the physicians that I work with, she's very insistent, you must do it for 30 seconds. And I'm like, I get bored in 30 seconds. So if I can get 10 seconds to do this stretching, then I think it's a good start. So this is for stretching. All right, next trivia. Wonder Woman used her, which, lasso, yes. If you watched the recent Wonder Woman, you would have known that too. Okay. So we talked about the stretching, now we're talking about land-based exercise. And I break it up as land-based and water-based because water-based is the most optimal place because the kids are more buoyant, and if you have a little bit of strength, then at least you can get some strengthening in there. But also to recognize that we don't live in the water, we live out of water, so we still have to do land-based exercises. So they're broken up as passive, active-assisted, isometrics, active, and resistive. So what is passive range of motion? Passive range of motion is literally like stretching and making, improving or maintaining your range of motion. There is no strengthening on that part. That is all the strength of the parents. And the only one that's getting stronger is the parents. So I really am not a big fan of passive range of motion. Active assisted is when the child is doing a little bit, and then the caregiver is helping as well. So you can use devices, equipment, some kind of ways to do these exercises. Isometrics are just a way to strengthen the muscle without moving the joint at all. So a lot of times with kids with contractures, that's what we may have to do, just do isometric exercises. And then I already talked about active and then resistive. So those are just the range of exercises to do. This is kind of a schematic that we have in terms of, let me start to see. Okay, I don't know how to use this, so I'm just going to pretend. So as you get stronger, you move towards more difficult exercises. So the highest, the most difficult is the one where you have to do recreational aerobics, PREs, isometric strengthening, stretching. But then if you are weaker, then you have the active assisted range of motion. And then on the bottom part is the amount of strength that you have. Gravity eliminated is if you're doing it in a position where gravity is not pulling on you. So when I'm standing up, bringing my arms above my head, gravity is working against me, and that's harder for me to do this exercise. So if you want to the therapist should kind of look towards what would be the most feasible exercise for you or your child. Okay. So what is Aquaman's amazing power that he does not have? I did not know any of this, so. He does not have complete control over the water. I did not know that, so. Okay, so the next has to do with water-based. So there's a lot of equipment that is available for someone to do strengthening in the water. So just walking in water itself is very beneficial, but then using equipment, flippers, these are hand dumbbells, these are like wrist weights kind of thing. And these you use in your hand, and as you increase your surface area, it makes it harder, so that's the strengthening in the water. That's what you want to do. And then to make it fun, you play basketball, Marco Polo, flippers for the lower extremity, and then, like I said, volleyball. And then noodles. Noodles can come in a variety of ways, and they're very helpful. So, okay. So this is another trivia. Groot is part of which one? Guardians of, yeah, okay. And I have a little, what happened to that? I have a video for that one. Yeah. If it works. I did, it's not working, there we go. Oh well, sorry, it had Groot dancing, because that's my favorite aerobic exercise for kids who can do it, either sitting or standing, but music is the best way to exercise. You have a beat, you have a consistent beat, something more enjoyable than just doing it to boring old exercises. So this is one of the things I always recommend. And then not only just dancing, but singing, that's another one for vocal. Wind instruments. I tell parents I would recommend the tuba, but they would kill me, so we go with flute or recorder. So these are some other examples of things. So walking is a very good exercise for the kids that can't walk. Biking, whether it's arm bike or leg bike, so recumbent stationary bike, and then the arm bike. So they have these bikes that you can put that you get that is you sit in a chair and you pedal the wheels, I guess it's the pedals, but you can take that same little bike and put it on a table and then use it for your upper extremity. So that's fairly cheap. It's about $30. You can get it from Amazon. The only thing about that is that it doesn't have any kind of resistive component. It's just for pure aerobic and just moving your arm through space. So, and then swimming, we talked about that. Okay. This is towards the last. This is last but not least. So activity monitoring. So this is a big thing. There's a lot of buzz on activity monitoring. Everybody wants to get into the game. So there's lots of devices. So there's the research brands are the ActiveGraph, ActivePal, and then the APDM, which is another inertial sensor that we have been trying at NIH. So the ActiveGraph and ActivePal are very expensive, and they're generally used as part of research studies. But then the commercial grades are the Fitbit, the Nike Fuel Band, Apple Watch. There's many, many others out there. Actually, I'm wearing one right now. It's just a ring, so for the women who don't want to wear a Fitbit, it's a piece of jewelry, so you can do that. So one of the things that I plan to do is to have kids in a wheelchair use it on a daily basis to see how much upper extremity movement you're getting. The only problem with these devices, with the commercially available ones, there's an algorithm that looks at them in space, in three-dimensional space, so unless you're actually moving forward in space, it's not recording. But I played around with my ring, and I was just waved my arms around, and I talked with my hands a lot, so it did pick up a lot of activity. So if I can find devices like that, then I might start including it as part of some of my trials for the kids. The engineers will give me a hard time about it, saying that there's a lot of noise in these devices, but I feel like you have to start somewhere, and that's something that I'm willing to start with. So, okay. What team does Professor X mentor? I don't know this one. The X-Men. Oh, well, I guess so. Professor X and X-Men. Okay. So this is the last few slides. So these are different. I don't really want to spend a lot of time talking about different seating options and equipment options, but just to keep that in your mind that there are a lot of different devices. So a lot of times I get families come in and tell me that I'm using this, and a lot of times I don't know about it because there's such a huge turnover in the types of equipment that's available that sometimes I'm learning and I'm being educated from you. But just to keep in mind, there's lots of seating options. There's a lot of standing frames available out there. So my favorite are the ones that are more mobile. They tend to be more expensive, of course. There is an organization out there, and I didn't have that in my slide, but you might want to write it down. It's called passiton.org. They are a lending library. They receive donated equipment, and then they will give out equipment for families in need. So sometimes it's a very good place to start with trying a new piece of device if they have it available. It's a national organization, and then they will let you know if there's a Pass It On center in your area. So very helpful for them. And then the last bit is the gait trainers. So there's multiple gait trainers. So, and then of course the last bit is the wheelchair sports. Just recommending that everybody do that. So. I did not know this superhero. Who is a superhero? He's Firestorm. So, okay. So this is my last slide. So there's not a lot of research to show that exercise is beneficial, but we know that exercise and activity is very, very important. So early assessment and intervention is very important for contracture management. Avoid muscle soreness for fatigue. A lot of times families will ask me, how much should I do? I don't have an answer for you, but my answer to you will be how much, whatever you do today, and if tomorrow you're sore, then what you did today was too much. So so they're not able to, in the time, know that this is too much activity, but over time you'll figure out that, we went downtown, we went to see some sites at the mall, and, I was riding around in the wheelchair all day long, and then I'm really, really exhausted today. So yesterday, maybe those 5 hours that you're in the mall was really too far, and maybe you should only cut it down to 2 or 3 hours. So that's kind of how we would to temper in terms of how much activity to do. Avoiding eccentric exercise and the high resistance. Encourage activity, especially aerobic exercise, and then incorporating it into your daily routine. That's also very important. And the most important is a therapy holiday. As a physical therapist, I'm telling you it's okay to do a physical therapy holiday. It's really, really important for everybody as a family to just chill out and do nothing. So it is important to incorporate that in your year. There are times when it's very, very important to stay aggressive in the therapy, maybe after surgical intervention, maybe after a long-term prolonged illness, then you need to be aggressive. But then there'll be time when it's okay to just chill out and not do therapy, and that's okay. I feel like where I am at work at NIH, I can make that recommendation. A lot of times you won't hear that from your physical therapist because it's revenue generating, but it's very, very important, I think, for everybody to take a therapy holiday. Okay. So I wanted to thank everybody. I want to thank Cure CMD for inviting me. I hope I was able to provide you with some little pearls. And then this is the last slide. So, all right. Thank you. Just standing here, I'm going to contract my my bicep muscle and just hold it there. So that's an isometric contraction. Okay. She can do completely. Yes, exactly. Yeah.
No, okay.
So just holding in place, or just for your leg, it could be like instead of kicking out, just kind of trying to hold it so that it's in a kicking position, but it's not really kicking out. And then just holding your head in place. That's that's isometric contraction for your neck muscles, so that's very helpful. So that's very important to maintain whatever strength you have.
Well, thank you for clearing that. I had no idea. And then I just had one more question.
Yes.
From a physiotherapist's point of view, she's never seen anybody like Jordan, and Jordan's unique in her disability because the most people that they see are core strong, and then as you get weaker.
Right.
Jordan's opposite. Her fingers are stronger than her wrist, and her wrist is stronger than, and as you get in, it gets weaker. So she's never experienced that. So she really doesn't know what the care plan should be. I mean, she does myofascial releases, on her contracted and works on her neck and such, but what is recommended, or how do you know what should be recommended, or who do you contact so that they know that they're doing the right thing?
So there are no recommendations, but my email was there, and you can take my email, and I forgot to point out that everybody is welcome to email me later on if you had any specific questions. But that, yeah, I don't have any, in terms of what to recommend to you to tell your physical therapist in terms of how to work on the strengthening. But I can talk to you about that later, and then we can have a side conversation. Oops, sorry.
Hi everyone. I'm David Roye, and I'm a pediatric orthopedic surgeon. I work at Columbia in New York City. And I'm going to talk about scoliosis management in CMD. My partner David, the other David, is going to be talking about everything else. I'm only going to focus on the scoliosis question. So this is a recent study in Neurology that summarizes the natural history of orthopedic complications in CMD. And this was a study of 125 kids and with a mean of 10 years follow-up. And the orthopedic conditions that were noted included scoliosis that appeared at a mean of about 7 years of age, and included 3 kids with congenital scoliosis, meaning a building block problem that's not necessarily related to the underlying diagnosis. And 17 of that 125 had scoliosis surgery, so for a rate of more or less 15%. And almost all had respiratory impairment at the time of the surgery. Achilles tightness was also noted in a large number, over half, but only 4% had surgery to lengthen the Achilles tendon. And about 7% had congenital hip dysplasia, and of that group, only 3 had surgery. And then 11 of the group were diagnosed with foot deformities, and there was, again, not many of them were treated with surgery. So that's where we are just in terms of the numbers. But the problem is this is a slide that almost everyone who talks to you puts up, because the CMDs have a low incidence, and there's an insufficient evidence base to guide treatments, and it leads to variability in care. Most orthopedic providers don't have the experience in treating patients with CMD, and we've heard that comment from you today already, and I hear it every time I talk about the problems. So, surgery, when surgery is contemplated, what are we looking for? What are the indications for surgery? What are the goals? What is the prognosis, and how are we changing the child? And what kinds of surgeries do we have that might be offered? So the indications are individual and have to be related to the child's quality of life and the child's function. Is the deformity progressive? Are there skin issues? Will the surgery that we're proposing extend life? What does the patient want? What does the family want? Are we seeing decreased function? Are we seeing decreased endurance? We also have a preventative side to the scoliosis surgery that we're doing, that perhaps we're preventing respiratory and gastrointestinal decompensation. And then, is the patient in general good health at a baseline where nutrition and respiratory status will be? We've heard that comment from you today already, and I hear it every time I talk about the problems. So, surgery, when surgery is contemplated, what are we looking for? What are the indications for surgery? What are the goals? What is the prognosis, and how are we changing the child? And what kinds of surgeries do we have that might be offered? So the indications are individual and have to be related to the child's quality of life and the child's function. Is the deformity progressive? are there skin issues? Will the surgery that we're proposing extend life? What does the patient want? What does the family want? Are we seeing decreased function? Are we seeing decreased endurance? We also have a preventative side to the scoliosis surgery that we're doing, that perhaps we're preventing respiratory and gastrointestinal decompensation. And then, is the patient in general good health at a baseline where nutrition and respiratory status will be adequate to sustain surgery? So, and again, is that surgery going to make extend life? Is it going to improve the quality of life? And all the alternatives to surgery? And to turn the question around, do we really understand the risk of not operating? So, and this is particularly a problem when it comes to treating the spine. And then we have to measure the outcome of our surgery. And that we can have several outcome measures. One would be the level of function. Ease of care is also a way of measuring outcome. Positioning and skin and hygiene. The presence or absence of pain is another way. Looking at complications and how difficult the surgery was on the child and the family. And what's, I think, really vital is quality of life assessment. Because what really matters is not whether the x-ray looks good or whether the wound healed well. What really matters is how the child is. And has function been improved? Has breathing been improved? Has positioning been made easier? Correction of deformities, maintenance of bone health, management of pain, education and dissemination of information on therapy. We had questions about that today too. Provision of assistive technology to maximize function, and access to appropriate specialized orthopedic management when it's necessary. And directing patients toward research studies as appropriate so that we can get the information we need on outcomes and on the efficacy of our interventions. So scoliosis does exacerbate respiratory function and can help contribute to thoracic insufficiency syndrome, so that we have to think of the spine as being part of a whole. It's attached to the ribs and attached to the diaphragm, so we have the entire respiratory mechanism involved here. It's not just, our view should not just be to the blue part of the spine itself. It's especially important for kids with these mutations because they have a higher risk of respiratory problems, but the treatment, of course, is not isolated to one group of CMD kids. Scoliosis is more common in children who have axial weakness of the trunk, which makes all kinds of sense, because if you don't have a strong core, you can't maintain yourself against gravity, and so there's a tendency for the curves to appear and progress. I always mention this, and I know that all of you, to a person, probably know this already, but I always mention it, that there's a higher risk of malignant hyperthermia in patients with congenital muscular dystrophy, and the suspicion is even increased if there's a strong family history, previous difficulties with anesthesia, and of course the RYR1 mutation, which is a real important risk for malignant hyperthermia. So it can be spontaneously, too, non-anesthesia provoked, something to keep in mind, particularly in patients with the RYR1 related myopathies. So our patients are particularly susceptible to some perioperative complications, again, and this would be for almost any surgical procedure, but airway complications, problems with pain control. It's a very delicate management problem because since the kids have respiratory depression anyway, we don't want to give too many painkillers that would further depress respiration when you're trying to get the kid breathing on their own. So pulmonary complications, prolonged recovery times, and of course bed rest and the surgery itself can produce deconditioning. So we were just talking about the need for exercise. When I operate on my patients with CMD, I'm preventing them from exercise for a period of time, hopefully no more than about a week, but it's still substantial. Common comorbidities which need evaluation are GI nutrition, and we need to make sure that the child is getting adequate nutrition. Of course, that respiratory function has been maximized. And we have to remember that there are cases of primary cardiomyopathies in patients with CMD, arrhythmias, and even transient cardiac failure. So this is something which we need to attend to before major surgery, as we see in the spine. So what we know about the prognosis, and this is, I would describe as the not so good news. The condition, CMD is respiratory depression anyway. We don't want to give too many painkillers that would further depress respiration when you're trying to get the kid breathing on their own. So pulmonary complications, prolonged recovery times, and of course bed rest and the surgery itself can produce deconditioning. So we were just talking about the need for exercise. When I operate on my patients with CMD, I'm preventing them from exercise for a period of time, hopefully no more than about a week, but it's still substantial. Common comorbidities which need evaluation are GI nutrition, and we need to make sure that the child is getting adequate nutrition. Of course, that respiratory function has been maximized, and we have to remember that there are cases of primary cardiomyopathies in patients with CMD, arrhythmias, and even transient cardiac failure. So this is something which we need to attend to before major surgery, as we see in the spine. So what we know about the prognosis, and this is, I would describe as the not so good news. The condition, CMD, is not static. Has I got it? I don't hear it. Hello, hello? Is that okay? The condition is not static. It can change, and we don't have high-quality long-term studies to document that. And the three areas of progression are in ambulation, respiratory function, and scoliosis. This is from my orthopedic point of view, anyway. So these are all things that we need to be watching for. And it's true in many neuromuscular conditions, even though the condition is not progressive in the usual sense. The effect on muscles and growing bones accumulates with time and with size, so that the kid whose weak muscle was adequate for running around when they're 3, 4, 5 may not be adequate for running around when they are 12, 13, 14. So these are things that we need to keep our eyes on. So the surgical treatment, I'm not going to get technical. I'm just going to make a few comments about the different types of surgery. This is the reason for our concern. If you look at in the first year of life, the whole thorax ribcage is less than 10% of its adult size. And by age 2, you can see that a large proportion of the alveoli have formed. So this is the alveolar proliferation, growth of the air sacs in the lung. And if you look at the 5-year-old, the chest wall is only 30% of its adult size. And then by age 8, you can see that the kids basically has reached this plateau of alveolar proliferation, so that all of us sitting in this room had our adult number of air sacs in our lung when we were 8 to 10 years old. And then, so we want to maximize that growth during that first 8 years. And so that's why we're so concerned about early onset scoliosis in CMD patients. So at about age 10, you can see the rib cage is about 50% of normal, and then it's not until age CM no patients have that result. So in other words, so again, indicating that keeping the kid's spine growing is an important goal. So when do we think about surgery? Ongoing progression with curves greater than 30, and because we want to avoid loss of ambulatory skills, we want to not to see decreased sitting endurance, and we We don't want to see that short trunk with the resulting GI and respiratory and cardiac function problems. And never forgetting about pain, because pain is a product of spine deformity. So the surgery decision algorithm is an observation every 6 months with the x-rays as indicated, considering a spine brace for the curves between 20 and 40 degrees, again determined by the ability of the child to tolerate it and the timing. Consider surgery when the curves are greater than 35 degrees and likely to progress because of growth. And strong indications for surgery in progressive curves that are over 40 degrees. So non-surgical treatment also exists. We have physical therapy, in-chair positioning devices, TLSO and soft postural braces may delay surgery. Bracing can improve functional stability and maintenance of position in the chair. And many braces have been developed to accommodate comfort, respiratory function, and G-tube function. So so improving function would include sitting balance and upper extremity use. It doesn't arrest the scoliosis, but it may delay curve progression and let the kid get older and bigger. It may delay the need for definitive treatment by and allow for lung maturation or allow for some trunk growth. So this is wheelchair modifications and soft spinal orthoses can be used. Casting can be used. This is an example of crest rolls that can help to lift the rib cage out of the pelvis and control the brace migration and level the pelvis. This is an example of such a brace. And braces that can help control the overall posture of the child also can be used and can be effective. So the risk factors that influence surgery. So promoting surgery is age and skeletal maturity. And so if a child is skeletally immature and young when the curves appear, we're more worried. Pelvic obliquity of more than 50 degrees, in other words, a pelvis is not level. And then our goals of care and quality of life, pain would be included there as well. Discouraging surgery are things, the comorbidities that exist in many of our patients with C&D, and including infection, pulmonary issues, cardiac issues, and malnutrition. Successful surgery makes positioning and sitting easier, and the gauge of success really needs these surrogate outcome measures that we talked about as burden of care or quality of life. Again, not the residual curve measurement or the appearance of the x-ray. It's really how the parent, caregiver, and the patient gauge their quality of life after the surgery. So here are some surgical options I'm going to discuss. I want to talk a little bit about halo traction, fusion, and growing rods, and pelvic fixation. We use more and more halo. It's very effective in reducing extreme deformities, and particularly the deformities that are in the sagittal plane. That is to say, kyphosis, where the butt spine's going out and back. It's really hard for us to correct kyphosis with existing systems, particularly growing rods. So we would use traction sometimes for a couple of weeks in the hospital in order to correct. There's often an amazing improvement in pulmonary function when we put the kids in traction, because it kind of lifts the whole rib cage off the pelvis and helps with pulmonary function. The posterior spinal fusion is what we do these days. We really don't do anterior surgery anymore, and it's. I think that if anterior surgery is recommended, you should perhaps question the surgeon about that, because it's really not where we should be going. The curves of 50 to 90 degrees that are progressive or interfering with sitting or standing balance are the curves that we're going to be fusing. Patients in general over 10 years of age, under 10 years of age will be doing likely growing systems, and patients with stable nutritional and medical status. Fusing to the pelvis is very commonly done in kids with CMD, and it increases stability and avoids postoperative kyphosis or changes in the lower spine. These days we use a technique that puts the head of the screw under a lot of soft tissue, so there's less problems than what we used to have with prominence of limb helps with pulmonary function. The posterior spinal fusion is what we do these days. We really don't do anterior surgery anymore, and it's I think that if anterior surgery is recommended, you should perhaps question a surgeon about that, because it's really not where we should be going. The curves of 50 to 90 degrees that are aggressive or interfering with sitting or standing balance are the curves that we're going to be fusing. Patients go-to is the magnetically controlled growing rods. The ones that we use are called magic, a name which I hate because they aren't magic. But the lengthening procedure is very simple. We simply, the kid is outpatient, a device is put over the rod, and the actuator then lengthens the rod. And so there's no surgery, it doesn't hurt, so it's pretty cool. So it minimizes one of the main issues of growing rods, which is recurrent surgery, which can produce trauma in the kid and can increase the number of infections. Complications and risk increase by 24% for each additional surgery procedure. So that's a big jump, so it's nice to avoid that. Early results have been favorable with reduced number of surgeries and comparable correction. Just our experience now is going on to 4.5 years, almost 5 years, and we have 48 patients. And what we're noticing now, though, is that follow-up is always humbling. We're seeing more actuator failures. In other words, the little device that does the lengthening. And if that fails, then we have to take out that $25,000 implant and put a new one in, which is not good for our patient. So, but that is something that, again, it's not a cure-all solution to the problem. There is very little in our literature that's just about CMD. This is a paper from Japan, which a case series of 10 patients that showed good outcomes at 2 years post-op. And this is a look at what surgery does to measured FVC, and you can see that if you look at this, we get an improvement right at the time of surgery, and then at 2 years, a decrease. And so you say, well, then why am I doing this? The fact is that if left alone, there likely would be a drop-off as well, and probably more. And again, it's really hard to get these studies done in most kids. They really can't cooperate with the standard pulmonary function exams. So again, this is another reason that we prefer using the pulmonary domain on a quality of life type instrument, which is, I think, more telling. And on those, we've seen real improvements, particularly in our patients with SMA after these surgical interventions. So kids with CMD have complex healthcare needs, and obviously, as you've seen here, they need that multidisciplinary involvement. In addition, they need an integrated and coordinated transition to adult care. And this is really a problem. It's one that I have addressed at Columbia with the creating a center that provides lifespan care. So it's hard, because once your kid hits into their 20s, a lot of the pediatric providers are not able to help you anymore. So as a lifelong care provider of children and now adults as well with neuromuscular problems, most of my regrets looking back over my experience have been kind of my failure to be proactive, my sins of omission, if you will, as opposed to sins of commission. I do advocate for active follow and active treatment of my patients, and I would tell those of you sitting out there with CMD, keep it up even when you're an adult and more or less in charge of your own health care. Don't just stop going to see the doctor. So thanks a lot. Should we take a couple of questions now, Rachel? Okay, yeah. In the back?
Excuse me, I don't speak really good English, but I was just to try to understand if any this the surgery for the spine or for the knees or anything like that for the bone, it is affects if the kids they have collagen 6, how it is work with the kids they have collagen 6.
Well, David's going to be talking about hips and knees and feet and things like that, so we're going to get into that. And you saw from the article that I discussed briefly that even though these deformities exist in CMD, they're not usually treated surgically. And the reasons are the ones that I was mentioning, is because the assessment for the need for surgery is around the function of the kid, whether the kid's having pain, whether the contracture or dislocated hip is interfering with positioning or function. And if these problems are not creating functional issues or pain, then perhaps the best way to treat them is not surgically, is with conservative care. But David's going to be discussing that. Yes?
So our daughter had, I believe, posterior spinal fusion surgery, and it helped with her lung capacity and the organs and all that, and the scoliosis, but there's no flexibility, right, in the trunk. No flexibility in the trunk.
Yeah.
It looks like perhaps her pelvis might be off center, off kilter. Mm. Is there at this point in time, from your research and your knowledge, is there a follow-up surgery to kind of, coordinate what's permanent rods in her back with her pelvis so it aligns better?
So in general, both with what we advocate is with growing rods and with the posterior spinal fusion is to take the instrumentation and fusion to the pelvis to control that. It isn't always done that way, and so if it's not, and the pelvis is free to move, then it's possible for pelvic obliquity, the tilt of the pelvis, to increase with time. And if it's interfering with function, so if it's causing pain, for instance, or an individual is weight-bearing on one hip or the other, seating is becoming increasingly difficult. It can be revised to the pelvis. In other words, we're capable of doing kind of adding on to correct the pelvic obliquity, but it is a major surgery, and so we don't do it very frequently. We'd have to have good reason to do it, which would include, again, seating, pain, skin problems.
So you talked a lot about treatments for scoliosis. How do those treatments apply to lordosis and other spinal deformities that are attributed to the same
Right. So there's, we think it is true when we're talking about this, we say scoliosis and don't specifically address the sagittal plane, which is the sideways plane, and lordosis is always an issue in CMD, or I shouldn't say always, but very frequently is an issue, as is kyphosis. And so that all of those have to be addressed. So one of the ways in the early onset and the more severe deformities that we try to help that is with preliminary traction. So as you kind of lift the child with the traction device, the sagittal plane also stretches out. So that's one way to treat. The other thing that we try to do, we want to leave enough lordosis, particularly in the ambulator, that the gravity line gets back, because if we correct too much, then there's a tendency for the kid to fall forward. So it's a real balancing act. But we can, in a sense, we can, with these multiple screw fixation devices that we use now, we can kind of put the spine where we want it in 3 dimensions. The other thing that can interfere with that is the quality of the bone and how fragile the child is. So if I'm in the operating room with a CMD patient, or with any patient, my first consideration is safety, right? I want to get her off the table safely without excessive blood loss, without doing things that are going to metabolically challenge the recovery. So sometimes that interferes with our ability to actually get as much correction as we would like. That often leads to I would mention that I always tell parents that we're going to do our best to get this done today, but if it's not safe and if I'm worried about anything in terms of our monitoring or blood loss, we'll just stop and let the kid recover for a week and then come back and finish. You have the, yeah, please.
Is bracing the gold standard or the standard of care for CMDs for treatment of scoliosis? I seem to be getting somewhat mixed messaging from our medical team as compared to what I hear at events such as this or researching online.
Yeah, we are starting to, it's interesting. My short answer is yes. I think that bracing should be tried. And it's a very much an individual thing. There are kids that just flatly don't tolerate it. And and I think that, and there are kids in whom the curve just keeps progressing despite our attempt to brace. But there are I would term it a substantial minority that do benefit. And again, it doesn't, when you look at studies that have been done where you use surgery as the outcome, so you have 2 groups of kids. One group of kid is braced, and your only outcome is surgery yes or surgery no. And you have another group of kids who are braced as surgery yes, surgery no. So that criteria, bracing doesn't help. So it's kind of like so in other words, the kids still end up with surgery, but that surgery may be a couple of years delayed, which would be substantial in terms of growth and development. The delay also means that we have more bone to work with, and so technically it's a little bit better. So there are some advantages to that, even though it may be that the bracing is not going to be definitive. It still can be very helpful.
I have a question.
The vertebral body tethering and stapling, is that a possible option for CMDs or for earlier intervention? It's less invasive?
So there's a huge drop-off in the number of tetherings being done in North America because of complications and failures. That's number one to know. We're talking about AIS, of course, in typically developed children. This is me personally, I'm against it because you have to go through the chest to tether. So if you're operating on the vertebral body, you have to do a thoracotomy. I mean, even if you're doing it, thoracoscopically, you have to put that lung down and to give yourself access to get I've done the cases. I mean, it's a cool surgery, but the problem is the average CMD kid cannot afford to lose even a little bit of pulmonary function or to have that permanent scarring that occurs because of the traversing the chest wall. Now, if you were doing a lumbar tethering, theoretically that might help, but the other issue is that tethering is not good at maintaining the sagittal plane, as we were just talking about. So that's another strike against it when it comes to CMD.
Great. I guess I could also say from our center's experience with one individual who's now involved in a trial, that neuromuscular cases such as CMD do not qualify. And he's done over 200 tetherings, my partner, and he's had, shall we say, suboptimal outcomes with neuromuscular populations such that he stopped doing it. So I think that's two major centers with the same experience. So anyhow, I would just say it's a real pleasure to be able to speak to you, and hopefully you'll find some of this helpful. I think it's more a discussion or a philosophic discussion than it is one that's evidence-based or anything like that. How many of you, can you hear me now? Okay. So how many of you who are patients or families have had members that have had contracture surgery? Okay, so a small number. How about surgery for hip dysplasia? Okay. Okay, so anyway, I'll try to present more of a philosophic approach than anything else. So I think one thing I've learned over the last day or two is the immense activities that have gone on in the basic science world, and some very high-level science that has increased our understanding of the disease process, the genetic basis for it, and essentially turned from lumpers to splitters, because now we've got all these things over here. I can't even remember them, nor I have no idea what they stand for. So we have an uncommon disease process that's quite heterogeneous, and for an orthopedic surgeon, I'm into phenotype. Genotype doesn't help me. So what are the take-home messages from the lecture, the way I feel about caring for your families and your children? One is that even the contracture work and the musculoskeletal care can best be done in a multidisciplinary setting, you know that, and care should be individualized, particularly for contractures and hip problems and as so on. Second issue would be that everything should be linked to some specific goal, right? If I just operate on everything that was abnormal on a physical examination, I'd have to clone myself 3 times, and most of the work I did would not be of any use to the patient and their family. So we have to define goals. Then a realistic plan for rehabilitation, because I would argue that often the surgical part of this whole thing is a small step in a longitudinal process that goes for years. And to a certain extent, it may be jump-starting that process, or it may be catching up to restart the process. And most of the time, even with a single event surgery, you can't correct these deformities. So that's why I think nothing happens in isolation, and it's a process when we're addressing contractures. And then once we all work together, I would work with my neurologic colleagues, our physical therapists, everyone involved, patients, and so on. And if we choose that we have a functional goal and we're going to try and get to that place, then of course it's up to me to discuss with families what technical solutions might be pursued to achieve that goal. So I think that's kind of the idea that I had. So orthopedists are interested in phenotype more than genotype. And so to me, it's a concept of shared decision-making. I should be able to explain to every family what I think it takes, what's going to be required, what the risks are, and we have to set a goal together, and we have to work towards that goal. And so I usually, I think for all of you, when you're approaching any healthcare provider, particularly when it's something like orthopedics, you have to think in your mind, like I'm thinking as I look out at you, like how can I help? Like, what are you thinking about what you see or what you're experiencing, and what can I do for you? What limitations do you have in your daily living? What do you wish to achieve? I mean, things aren't always as straightforward as, well, this is my dominant arm, and I'm unable to flex my elbow to feed myself, so therefore my specific aim is to increase the range of motion of that joint so I can feed myself, right? So that's a pretty straightforward example of that. So here's just the whole concept of impairment versus disability, right? So I don't think there's any of the patients that all of you are here together today that don't have some degree of an impairment. You have loss of motion at a joint, or you have some weakness, or it goes on, and one could make a list for every single patient. So here's a fellow, I don't know the history because, but you can see here that he's lost the entire part of his upper ulna. He has some screws. He probably had some surgery. It probably got infected. His radius is dislocated. So essentially, this fellow has no elbow joint. No elbow joint. So if I showed this to a group of orthopedic surgeons, they wouldn't want to take the history. They'd be, oh, well, we can do this, or we can do that, or we can do this, or whatever. But in fact, this wasn't even a patient. This is the patient's father, and he was just showing us what he could do with his arm, that he was a manual laborer, and he had no symptoms. So he had a pretty profound impairment, but he had no disability at all. So we got on with taking care of his child. So this is a nice conceptual model for, for being able to, just another way to think about things, right? I haven't heard any of this discussed, so I figured let's talk about it. So we talk a lot about these impairments, body function and structure. We can, again, I have a loss of motion of my knee or my elbow, or I have my foot is turned inward, or whatever you want to say. Or on x-ray, my hip is displacing out. The key question is, how does that impact our activities and our participation, right? What are our aims? So if you're sitting in, just for example, if you're sitting in a chair all the time or most of the time and you're completely comfortable with that and you can't straighten your knee, but it in no way causes you any change to your life, well, I'm not going to press you to operate on that. I'm not quite sure what I'm doing. And in fact, if you stay in that position 80% of the time, what in the world would make me think I can keep it straight even if I got it straight? So these are the type of discussions that we have to think about. What are we going to do to enhance activities and participation? And then these elements I'm going to bypass, but certainly when you go around the world, the issues of environmental factors and personal factors are much more profound, particularly environmental factors. And I know throughout this meeting I've heard some of you are living in more remote communities where not all of the services may be easily accessible, and those are the kind of things I'm talking about. But so anyhow, activities and participation. So we're dealing with a group of different individuals. So some patients are walkers, and the question would be, can we maintain or improve function or reduce pain? For example, I have, operate on a very, very small number of patients. So again, I'm talking more in theory, and I'm melding together different disease processes. This isn't unique to CMD. But for example, let's say you're walking and you develop a bit of a hip flexion contracture. And in your population of patients, that is I'll show you, it's very similar to a type of contracture that's exceedingly common in polio, and it destabilizes you a bit anteriorly. Well, that's going to affect your ambulation and lead to some deterioration. So then we may then want to address that specific complaint to get you back and try to keep you back on track because you're having a deterioration in your walking. Okay, well, how about if a patient does not walk? So then can we achieve upright mobility with or without an assistive device? And I don't have an answer to be able to look at a child who has not yet gotten up. I have some ideas, but in other words, sitting all of us together or with a family and a multidisciplinary team, what are we shooting for? And what is it going to take to get there? Is it even possible to get up and walk? And I'm going to show an example about that. And then if we have all decided and come to the conclusion that ambulation is not a goal for us, then perhaps we need to focus on, well, what are other things we can do to improve seating, positioning, comfort, ease of care? And not just ambulation, perhaps being able to be positioned in a prone stander or a standing frame is our goal. Well, that's a different story. That may be a very important goal for a particular patient and family, in which case we can try to achieve that goal. And then, of course, we have a bunch of services that always work in combination. Like I said, a surgical intervention is pretty worthless in the absence of a functional system to make it work. Okay, so here's just another example of the same sort of thought process. Now, if we were together and we dropped down into a polio camp and we saw 200 patients together and we had resources to operate on 40 of them, who are you going to operate on? There has to be some goal. And so these may look fairly similar to you, although there's subtle differences, these patients. They all have significant contractures and weakness. But 2 of these patients can be walkers with fairly straightforward orthopedic procedures, and 2 of them will never walk. So the key is get to the kids who you're going to get to that level, and don't put scars on the kids who you're not going to get anything out of. So this young man and this young man don't have upper extremity strength or trunk control to be able to utilize an assistive device and to be able to walk in a meaningful way. Whereas these fellows here, this child I know because we operated on that child, and that child did walk with simple orthopedic surgery. So what are the contractures from? Well, there's progressive fibrosis within the muscle, but I would argue that there's very significant positional influences, right? We sit a lot of the day, and so we try therapy, we try all these different strategies, and we try to, be able to maintain the range of motion of the joints, but it's a very difficult, a worthy opponent. Contractures tend to occur, they tend to recur, they're very resistant, and it can become a challenge. The other issue is, or the idea that the contracture solely involves a muscle. It's just a tight muscle. It's usually not just a tight muscle, and invariably, particularly around the knee, this contracture involves the structures of the knee joint, the knee capsule, so that simply lengthening a muscle is not going to achieve the goal that you'd like to achieve, at least right away. So I'm sure you're all aware that most of the contractures are flexion contractures, hips, knees, ankles, fingers, so on. And so now I thought moving on to, so now we have some sort of at least a philosophic background and something for you all to think about when you're, going in to see your health providers and trying to sort through these issues. But then once you get to the point of trying to do something, then of course you have to come up with technical solutions. And so to a certain extent, we can try and prevent the contractures, and there are strategies for that. And you've already heard about physical therapy, and I can discuss bracing as well as the reactive. So how about, you've heard about positioning and the physical therapy, and how can you not emphasize, as you've heard before, integrating this into a lifestyle change. Nobody wants to do exercises or stretching every day. It can be painful. And so while I don't have an answer, at least of how to specifically do that, at least conceptually, it makes a lot of sense. Orthotics are another issue. And again, there's no strong science to support this, but I guess the idea would be that an orthosis maintains the position of a joint. And then there are several different types. And the reason why I've underlined dynamic here is that although I haven't extensively reviewed the literature on relieving contractures with the use of dynamic splints, there is some evidence out there that dynamic splints are effective. And so while I'm not quite quoting the paper here, I think when I discuss with families, particularly, not necessarily, again, the same disease process, but when we're doing contracture surgery, particularly for knee flexion contractures, I try to think about what are we going to do 12 months from now? What are we going to do for 18 months from now? Because we don't want to be back in the same place with 2 scars. So sometimes adding dynamic splinting at night, either before or after, might be of value. So I just threw in a tiny bit about orthotic devices, and these 2 type of orthoses that you see, the supramalleolar and the UCBL, are foot orthotics. So they don't control the ankle. So they're probably utilized less in this patient population, whereas the ankle foot orthosis controls the ankle. And in patients in particular who have weak quadricep muscles, often a solid design or ground reaction brace are nice because they block the advancement of the tibia over the foot when you're walking. And assuming you don't have a lot of malalignment of the bones, twisting of the bones, they can actually help you to achieve better knee extension when you're walking. So those may be an advantage to control the positioning of the foot when you're standing or in stance phase of gait. They may also have a secondary benefit to give you some better control at the knee depending on the degree of weakness that you have, assuming that you don't have big knee contractures or torsional malalignment. So how about the surgery? We don't do much surgery, but the menu is essentially we can do things to soft tissues and we can do things to bones. And when you hear it's an issue of terminology, isn't it? So soft tissue lengthening or release. What does lengthening mean versus release? Or are they the same thing? Well, I would argue that sometimes if a soft tissue is non-functional, okay, functional versus non-functional. So if you have a polio contracture and the muscle has been replaced by scar tissue and there's no active functional muscle, nothing to retain or maintain, then that gets released. It just gets cut. It's just scar tissue. It's of no functional value. Whereas you take the example of a child with cerebral palsy who's walking with a flexed knee gait like this, whose hamstrings are tight, you're not just going to cut those muscles, you're going to do a strategy whereby you make them longer. When you lengthen muscles, you do make muscles weaker. So the idea is to achieve the functional improvement in range of motion without over-lengthening or weakening the muscle. Now, osteotomy, you're just realigning bone. Okay, so the issues of surgery, I think, that are particularly important in the patient population with CMD would be early mobilization. So virtually all of the soft tissue type procedures that one might consider would be candidates for rapid mobilization. And in the limited cases where I've done anything, particularly I've found more pleasing results at the hips and the knees, but we've had the patients admitted immediately after the surgery for a period of intensive rehabilitation. And I think there are a couple of reasons for that. We don't want to lose function. The other thing being the surgery is the first step, because you can't simply do a surgery and restore the full range of joint motion. That could cause you to stretch a nerve, or that could cause other problems. It often takes additional measures, be it serial casting, be it therapy, and so on, to be able to get that desired goal. And the other risk, of course, is this issue of recurring contracture. And I think that's a battle that we all face, and that's the requirement for a longitudinal plan of care in which the system will take care of the patient. Because if you just do the surgery and you don't have the system, you're going to end up right where you started, and no one will be happy about that. So here's just an example. This is a boy with polio again, and not to say that these two disease processes are the same, but it just so happens that in the patients I've seen with CMD, several who have been walkers, others who have not, they're getting these hip flexion contractures, and everyone assumes that it's in the main hip flexor called the psoas, which essentially is the most important muscle for initiating the swing phase or propelling or advancing the limb forward, initiating that, when in fact the psoas is not a player in this problem. It's not the main problem. So you can see here's a tight band of tissue, and actually this muscle goes behind the knee all the way down and can also contribute to a knee flexion contracture. So if you have this contracture, your child has this contracture, the picture on the right is a little bit awkward, but this is the way that we assess this on physical examination, and it's also a nice way to work on stretching it. And that would be, with the hip brought up like this, you try to extend the hip as much as you can and you internally rotate it, and then if there's a contracture, of course the limb stays up in the air. Ideally, this boy's limb would drop down, so you can do your stretching in this regard. But for me, it's the way I evaluate the patient during the clinic visit. So here's just an example. This is a very extreme example. Again, this is a case with polio, but this fellow was 17 years old and he'd never walked before. His knees were stuck about here and his hips like that, so it was unbelievable. And his foot and ankle weren't too bad. They were flail, but they could at least be positioned or braced. So I know this seems really, this is not the Spanish Inquisition or anything like that, but you know, in my residence, whenever we use traction on the extremities, I think our trainees think we're dinosaurs or something. But the reality is, when you have very severe contractures, just like Dr. Roye showed the halofemoral traction for severe spinal deformities, you can't take that boy who's lived like that for 16 years, do a simple surgery and pop his leg straight and get up and go. It's a gradual process. So anyhow, so he's put in traction, and this pin is keeping his knee joint from dislocating, and this one is pulling traction. And so he's in there for about 4 to 6 weeks, and it worked. He's straight, he's standing, And then he's now a champion for kids with disabilities in this country. And this is Nepal, and this guy was born in the region of Mount Everest. So even extreme contractures can be treated if we have sort of a longitudinal program. Okay, the knee flexion contractures are the most difficult. And I think probably one thing to consider starting with is stretch casting. Then we've got the soft tissue procedures, which I'll talk about in a little bit more detail. But anyway, you can, and then the bony procedures, which would be guided growth and extension osteotomy, and then external fixation. So I'll just try to go through. So this is just a menu of options that could be applied in the treatment of a flexion contracture of the knee. I don't mean to advocate for any one particular thing for your child. And for example, external fixation I didn't even discuss. That's where you have thin wires or wires are placed into the bone, and you have an external frame which is gradually stretched to achieve the correction. So when you're stretching at home, one thing to keep in mind is with this knee flexion contracture is that if you simply pull and try to straighten it, as time develops, the tibia will go posteriorly on the femur and you can get a subluxated knee joint. So if you're working on your stretching exercises, it's important to put your hand behind the upper part of the tibia and pull it anteriorly while you push down on the distal femur. And that's kind of a way to help stretch without having the tibia to go posteriorly on the femur. This is just an example of wedging cast. This is from Uganda, and showing a particular technique for how to wedge a cast. And then others like to use, they apply a long cast and then cut out the anterior part, work on progressive stretching exercises, and then replace the cast. So when it comes to soft tissue surgery, I think I had mentioned that. So dealing with the hamstrings can be tight. They're the muscles behind the knee. Depending on the degree of tightness, depending on whether or not they're functional on these issues, one can actually lengthen the muscle or one can release them. But invariably, the posterior soft tissues around the knee joint are tight. And doing a posterior capsule release of the knee, most of us find that that's it's quite an extensive operation. It's very prone to rescarring. And in general, it's also pretty high risk for nerve stretch injury or vascular problem. So we don't routinely perform that type of an operation. So I think I always start with serial casting and then try to do my best to get things corrected with that. There's another strategy that I mentioned for the sake of completeness. Here you can see two plates, and this is the growth plate of the end of the femur. The two plates, this can be done as an outpatient. I recognize there are lots of anesthetic issues, but in a more general sense, these are placed, and then these stimulate the bone to grow abnormally so that you actually can correct the contracture by creating a bony deformity. It takes about 1 degree per month. This is infrequently reported and infrequently used, particularly in the neuromuscular population. For completeness, I mention it. You can also realign the bone through an osteotomy as shown here, and that's done very commonly for other disease processes, but much less commonly when you want to rapidly mobilize the patient, because typically you need at least 2 to 3 weeks before you can stand on it. So I've probably done 100 of those in children with cerebral palsy, but I haven't yet found the occasion to do in other processes. So around the foot and ankle, again, the most common thing would be equinus, and also here we call it equinovarus, where the foot, the Achilles is tight and the other structures are tight and it's inward. And depending on the functional, what are the potential indications for doing anything? Well, I suppose we'd have to all talk about it. It could relate to patients being destabilized in their ambulation. It could relate to patients being in a very cold climate who can't wear appropriate shoe wear, who need to get their foot flat to wear the shoes they want to wear. It might relate to other reasons, so that we can discuss. And the last issue to talk about, I hope I'm not going too long, but the last issue to talk about is the hips. And as Dr. Roye showed, hip dysplasia is not all that common. In this particular example, you can see here's the femoral head. It should be down here. So this hip is dislocated. And in these cases, this hip these hips are partially out of place. They're subluxated, but they're not completely out of place. So the question is how to frame it in a very rare disease where there's phenotypic variation. Do we model our recommendations to you based on spastic hip disease or flaccid hip disease, or is it in the middle? So when I'm thinking about it, we can just say that most of our experience comes from dealing with spastic hip disease, in which hip displacement is very common, in which hips that are completely dislocated are commonly causing pain and arthritic changes, in whom we often have to do salvage surgery in teenage years, or my adult colleagues mention that this becomes a problem as many of those patients go into their adult years. The flip side of that is patients, for example, who have flaccid hip disease, like polio or spinal muscular atrophy, where conventional wisdom has been that you don't do anything, because technically it's harder to keep the hips in, and the children don't have the appropriate muscle power and balance, which is important for keeping the hips located. So be it right or wrong, the traditional approach in flaccid hip disease has been to leave the hips out. This is being discussed, and convention is being challenged in the SMA population. So I think that, again, this is individualized, and I think I would approach the CMD population on a case-by-case basis. I don't think anyone's got a series of these that they've taken care of. And whereas I can easily say I've done 100 hip reconstructions for other pathologies, I've not yet done one in this population. Then I guess we also could frame the issue as to whether it's one side or both, and whether the patient is a walker or a non-walker. But anyhow, so it looks like we've had it here on the, I think you've been saved by the virtue of the computer running out of power. So I guess as the slides were to continue, unless I can quickly reboot something, actually maybe we can take, I can ask you for your thoughts, your comments, or your questions on the management of contractures.
We have a question from Jillian. I have a question about contractures of the knee. My left knee is contracted inwards due to the severe tightness in my hips. I already have tension release surgery in 2007 on hips, left knee, left ankle, and knee. My orthopedic doctor wants to release the gracilis muscle now. What are your thoughts on that?
Where's it coming from?
Live stream question.
I'm looking around for who's talking to me. I guess it's really hard to answer that without talking to you, getting the history, knowing what was done surgically before, and examining you. Whereas traditionally, I think that I have not found a great deal of success with doing revision lengthenings with hamstrings. Again, I have to justify that by saying it's been in other patient populations. So I essentially try to serially cast everything before operating, but I guess I apologize for not being more specific with the answer, but I think I would examine first.
So I'm not a surgeon, so I'm not, but I think what you would want to know is what would be the purpose for the lengthening? So the thing would be, is that to help her sit comfortably in a chair, to help her with walking? I think those are the questions you would need to ask in terms of before she goes further for the surgery, is something that I would probably counsel her to talk with a surgeon, and because that would be very important to know. If it's just to lengthen because you've got knee contracture, that would be not helpful. But if it's to help with doing a transfer out of the chair, if it's to help to stand, getting in a stander, those would be the reasons why I think that, you would want to consider that. Are there any other questions while he's trying to?
Yes. I have a question about bracing. I feel like every doctor that we go to and therapist would like to have my daughter braced from head to toe sort of at all times. She sleeps in hard plastic hand braces. She's in AFOs 20 hours a day. She wears a DMO from head to toe. And I don't really know why. So she's non-ambulatory, non-weight bearing. So specifically for the AFOs, I see a lot of kids here without AFOs on, and so does my daughter, and wants to talk about why they're not having to wear braces. So I know it's a philosophical question, but why? Is it necessary?
So let me answer the question about the bracing and the DMO. So my first thing has to do with the DMO. There is no evidence to support that it helps. That I've seen a lot of parents come in with the DMO. I don't know if you know, if it's like a body jacket kind of neoprene suit that kids wear. And the idea is that tactile input helps them stand up straighter, sit straighter. But my feeling with that is that it's like white noise. So if you have something that you're wearing, after a while, you just ignore it. So initially, the videos that we get are amazing. Like, look at this before and after. Like, before they had the DMO, they were just slouching, and now with the DMO, they're standing up straight. But see what happens 2 hours later, they're still doing the same. So I've had kids wear those DMO things in the middle of the summer, and the kids are itchy, and so I think those are proposed by physical therapists because that's another way of revenue making, and so if it helps your child, great, but I don't think there's any, if you have to allocate resources, it would be not that would be not where I would put it. In terms of the bracing, the resting hand splints and the night splints, I'm not a big fan of night splints, but there are times when they need to be on. And the reason why I'm not a big fan of night splints is kids don't sleep well, and then you don't sleep well, and everybody's cranky the next day. So I think you have to kind of agree with that. So I think there are therapists that will go out there and say, no, you need this, and and they're all, and the time in terms of wearing braces, I've had so many people come to me, oh, my therapist said I should wear it for 20 hours a day. And my response to that is most hours of the day, most days of the week when you're upright standing for AFOs. And if you're in a chair in an AFO, unless you're using it, unless you need the positioning for the feet to do transfers, that would be the only reason why I would probably say. So I don't know if you agree or disagree.
I think I agree. I think in the absence of science, it's very hard to be dogmatic about these things, but this is kind of my opinion. My opinion is we all sit together in a multidisciplinary setting. We work with families and kids, and we respond to things, and we try to be rational, but yet we try to offer whatever services are currently available, assuming they're reasonable. Other people ask, well, I'm doing okay, but is it okay to put the brace on every other night or something? I said, well, as long as we're maintaining the range of motion or achieving our desired goal, well, maybe you can wear it every third night. I don't know. I mean, the end point is the desired goal, whatever that be. If it's a flat foot for standing or for positioning on a wheelchair, well, that's the desired goal of that. So I think...
Yeah.
Yes.
I'm just falling.
Sort of been told by doctors in my elbow that some people, okay, thank you. I could speak loud enough, but this is helpful. I wanted to ask what your thought on this trade-off. I have an elbow contracture that is bad enough where I need help with dressing, but so far my doctors one set of doctors have thought, yes, this is possible, but another thought, and closer to my muscular dystrophy doctor, had warned about the consequences with tissue damage. I was wondering what your approach was in dealing something that is both and could potentially make me occupationally independent, someone like me more occupationally independent, but at the same time carries this risk of you lose the strength that is there. You lose the strength that is there.
I think everything's a balance. Which direction are you losing again?
I'm.
So you're trying to achieve.
It's a flexion contractor in my elbow.
So you're trying to achieve greater extension at your elbow. Well, I mean, you know, you can always start with, again, I mean, I'm always happy to fail with serial casting, and I mean, you can always start with serial casting and see, or you can start with, you know, a judicious soft tissue release followed by serial casting. Again, to me, contracture surgery is never about the surgery. It's about a program of management that may start with, for me, preoperative casting, then an intervention, and then some postoperative management, and then maintenance therapy. And again, you know, be it right or wrong, and I don't know if there's strong science, but the issue of, you know, using a dynamic splinting when you sleep, whether that's able to be tolerated or whether you can achieve, you know, and just how much do you have to achieve in degrees? Well, I don't think you have to be completely straight, right? So you have to be within some window that allows you to function appropriately. So for me, it's always starting off with simple things and trying to achieve that balance to get the goal. I don't know if that helps.
One of the things that I did want to talk about the elbow contracture is that we do things here, we don't do things out here. So I think that that is an issue that we've seen with a lot of the CMD kids that they, or adults, is that they do develop the elbow contractures because you're combing your hair, you're brushing your teeth, you're eating, but you're very rarely doing things out in space where you're extending your elbow. So, so one of the things that I always also recommend is that if you can, then work on activities that is making you go up higher. So putting things on a shelf a little bit higher, things like that, so you can use the opposing muscles. So it doesn't address the effect in terms of the stretching and the contraction, but at least you can do it actively to preserve.
This one definitely works.
Thank you. Excuse me, as I told you before, I don't speak good English. We are a Syrian refugee family. We moved so many countries. We're looking for really a good hospital for my daughter. She's another with collision 6. We at first, we was in Phoenix, Arizona. In Phoenix, Arizona, they another schedule for my daughter the surgery for the knees. So I don't know what's exactly the name from the surgery.
I'm not sure about the procedure they recommended, but she has pretty significant knee flexion contractures, and she's non-ambulatory, and some doctors have recommended surgery to straighten her leg. And I think you would like their input on that.
Yeah, what happened, they scheduled for her this surgery in Phoenix. But really, it was a big surgery. I don't really comfortable to do it for my daughter. So I started looking for my daughter. So some doctor told me, move to Boston. It is really a good hospital for your daughter. So I make a crazy trip from Phoenix, Arizona. For us, it is like really a crazy trip because we are refugee here. We don't know about all this stuff. We moved from Phoenix to Boston. In Boston, I canceled her surgery in Phoenix. It should be in January. So when I moved to Boston, and they scheduled for her the same surgery, it should be the next month, August 17. I come to here, I see the neurology team here. We talk about this surgery. They really don't agree with the surgery. So really got lost. I don't know what I should be do. I should be go with the surgery, or I listen to what they told me. And under Dr. Jean, she see my daughter, and she was agree with the surgery, what I understand. So please, I need help, please, please.
So I think these are really complicated issues, right? So one thing you've got is a whole bunch of people around here. A lot of them some of them have had this type of surgery and all can share something with you. I think treatment philosophies differ. I think I would start off with having to understand and knowing your daughter and the whole situation from arm, spine, schooling, the whole 9 yards, assistive devices. Then setting a goal. Is the goal that she'll be in a stander? Is the goal, what are the functional goals of what we're doing?
The goal really to help her. She now full-term wheelchair. The goal to help her to stand and walk with the walker, with the support. Not really the walker, it is the walker with the support. This is their goal. So it is really big difference for us to help her to move from the chair to the walker. It is a dream for us. So, but if this is the surgery, it is dangerous for her, I will not go with the surgery. I will keep her like what she now. I don't want to go to the worst by my choice.
Yeah, so I think, it's a really difficult question to answer, but I guess in our setting, and I'm sure you've been to good people everyone means well and everyone wants to get as much as we can get for every patient. But typically we just sit all of us together and again, establishing a goal, if everyone agrees that the goal will be upright mobility and the rate limiting step is the knee contracture, then it becomes a technical issue of, amongst the choices available to us, what would we recommend? Now, the knee surgery in and of itself, assuming the risk of medical complications was reasonable, the complications due to the surgery itself, I think, depending on what was advised, would be fairly low. And so, I think it's just kind of deciding whether or not it's reasonable to pursue.
Hi, I'm Sarah Newhouse. I work with Dr. Foley and Dr. Bonneman, and I got to meet your family last week. I think one of the concerns that was raised when we were discussing this was some unique properties, and Dr. Foley's not in here right now, but some unique properties with collagen 6 myopathies, and some adverse events that had happened in some of our patients that ended up with severe fixed contractures once the joint capsule was compromised and ended up with worse mobility after the surgery. And they were offering a very aggressive bilateral osteotomy, hip and knee, and torsion and fixation, and some pretty invasive measures that we were concerned might leave her less mobile. And then with progressive weakness and inability to stand, that even if her knees would be fixed, would it end up worse than where we started, was a concern.
Well, if that sounds like a separate issue. It sounds like it's a little bit more complicated but then in that regard, doing an osteotomy, you're not violating the knee, you're not touching those periarticular structures, you're not cutting muscles to that extent. The issues with an osteotomy, as I had shown, would be that it would be a couple of weeks of not being able to, but of course we're not bearing weight now. An osteotomy typically, from a technical perspective, doing an osteotomy depends on how bad the flexion contracture is. It's not technically possible to do severe flexion contractures. So usually we do serial casting and get it to a measurable level, i.e. 20, 25 degrees, and that can be addressed with reasonable surgical risk. I think you're talking about the inherent properties of the collagen and the risk of disastrous results from doing a big muscle release surgery.
Yes.
Yeah, and I think, again, so it may, again, it's hard to comment on an individual case without knowing anything, but if everyone if that was the issue, then it may well be worth the risk of doing the osteotomy because you're shortening the bone to protect the neurovascular structures. But again, it depends. I'd have to examine to see. Like I do a ton of those osteotomies. I do a lot, but for me, I have to get the residual deformity to 20 degrees or so. And I also shorten the bone to reduce the risk of stretching the nerve or having a vascular problem. So you can't do too much of an extreme correction even through an osteotomy. But we can talk about it afterwards. So it looks like we need I don't know whether it's Maalox or cup of coffee, or should I go through the last few slides? Or?